Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 190. We have a multi-vessel protected PCI this morning. The patient is all set, the Impella is in place, and let me take you to the cardiovascular laboratory where Dr. Kinney and Dr. Sharma are on standby. Samin, does it feel to you like 2009 when we started the first case?
The first case was, although that I would say that was even little more complex from the coronary anatomy, but right. Ejection fraction was actually 25%. This is even less than 25, but anatomy is not that complex. That was the rotational atherectomy, calcific, our left main LED, which is our sign code none, I would say. That's how we made our reputation when we did the first our CCC symposium on in June 1998. So yeah, that was the first case. So we are reaching there through case number 200. We are 190, as you said, and with same players, myself, Dr. Kinney. We are two fellows, Tushar Mishra and Jason Kaplan, and CVT is Asif and Naira. And nurses Will and Ashley, and imaging is Kiski. Whether when we'll use imaging, let's see. So this is and again we have not done actually Impella case in our CCC live in a long time. So that's why we say let's do it today. So with that note, we'll show the points for the Impella, but let me present the case.
And Impella has had a stunning journey between Abiomed and Johnson & Johnson.
Johnson, that's it. And from my point of view, Johnson made a big mistake. They've overpaid it. They overpaid because by year end, there will be 3 other devices of 9 French will be available, and we know what will happen to 14 French Impella. And I remind everybody, the topmost DES at time Cypher started in 2002 and 2009 became 0 when the new DES came. So it's always the issue. But anyway, whatever we have at this time, we continue to use. And as you know, these are all the CME activities. These are the target audience, the overview, and the learning objective remain the same. That appropriate case selection and stepwise approach to performing complex coronary intervention and apply the principles and lessons from the recent or other relevant clinical trials. So this is where we have maintained that accreditation that you get a 1.5 AMA credit for having this, attending this live workshop, and myself, Kini, and you all are the same, our conflict of interest, and so. And these are our commercial supporters. Of course, anything big you want to do, you have to have support, and this is right here we have. And then, of course, in the end, you have to just fill up, go to the website, and we'll show you in the end of the case, and then you can get your certificate, you can print it. So this is a very interesting patient in the sense, 78-year-old female, presented with non-STEMI and CVA. He presented outside, but had both CV and non-STEMI in end of December, post-Christmas. And at that time was also in acute and chronic heart failure. She had known heart failure before with a low ejection fraction, reduced EF. But at that time, because of CV and non-STEMI, she was managed on the guideline-directed medical therapy and no cath done. Because, you know, many times, unless it's an evolving MI, so people with a CVA, they want to wait at least 2 to 3 months. That has been our policy also. And same thing actually for TAVR. So anytime we have a patient CVA, we delay their TAVR procedure for 3 months, knowing that this could be many or comes from the mobile atheroma. So this patient remained in heart failure class 2 and 3, despite good medical therapy. Rest of the factors are shown on the left side. Patient has some dysphagia. At that time, also a diagnosed new onset AFib and was started on oral anticoagulation. Rest of it, A1C is good, LDL is good, CRP was not available. We have sent CRP, we sent CRP routinely, and that actually has led to publication 4 publication on the inflammatory markers during PCI, being from the European Heart Journal even, and the creatinine is good, EGFR 46, and BNP, the last value is 1600. We have sent it again. Oh, CRP now actually tells me less than 3, so good. And BNP we have sent it. Patient did have a high BNP. So this basically story in this particular case, multiple good medical therapy. You can see it, including my favorite drug, which everybody hates it, Lenoxin. I didn't start it, but I still believe in Lenoxin. People don't. In all this, they're coming with a new agents with a dapagliflozin and all. And patient has a cardiac cath which revealed 2 vessel disease, which we are going to show you now. And low syntax score was not high, just 23, and EF was 22%. So based on all, patient was taken off, and CABG was recommended, but was declined because of comorbidities. And now Anu can show what we have.
So this is the left side. We are doing the picture.
Yeah.
So circ is the only vessel which is non-obstructive, and then you can see LAD, which probably was a culprit in December when she had her event, MI and a stroke.
Yeah, very ulcerated, huh?
Ulcerated. No, right now looks like it is. Look at the way it's behaving, like a coronary dissection. I'll show you more. Okay, ready? Go.
Yeah, you don't see in this view usually.
No, you can.
I mean, there is a question on the patient's history. How has her recovery been from the stroke?
Yeah, so actually very interesting. She got a physiotherapy in last few months, except some dysphagia. She's mobile, right? She walked in?
Yeah.
So she's mobile now, yes. Look at this. Looks like a spontaneous coronary dissection.
Yes.
Definitely, as AK said, wow.
Yeah.
Wow. Okay, now show the RCA.
So this is where we are, and this is the right coronary artery. Okay, let's
Bad
go
LV,
back
no,
to
show
the
the LV,
EDP. Yeah.
Bad LV is clearly less than 20%. So this case, although CVA is not a contraindication, she could have been randomized into the Protect 4 trial. We are last to the last part of the Protect 4 now, and look at the subtotal PDA. And at that level of the bifurcation, there is about main vessel has about 30% and mid RCA has about 70%. So there are basically 2 lesions. Question always will come, what are you going to do with the PDA? Just do at the ostium, or you have to do a double stent approach? I think, Anu, what's your plan on the PDA?
Just do the ostium and then another stent in the mid RCA. Yeah. And for the LAD, since we now see this, okay, wiring could be challenging the way it looks here. Yeah. But this is the view that is very challenging. You see that? That's one versus it was a subtotal vessel, and then it is still like an organized thrombus, because you do see like a filling defect here.
Yep.
Yeah. So that could be the.
And there is a calcium in the LAD, but in the mid where there is no disease.
Yeah. So here, yeah.
Calcium is further down.
Adventitial calcium probably, if you see it.
Keen to see, Anu, what is your first choice to use
the wire
for LAD?
Which wire?
Mine would be a Whisper wire. I actually even like the Choice PT, extra support, the hydrophilic ones.
Yeah, so I think mine will be the Whisper. Yeah. Let's see, there's a question already.
Let's take how many people are online?
Yeah.
How many people are online? Let's ask everybody.
Very hard. I can ask them, but there are more important questions here. What access sites have been left and right groin?
Good.
No, so access site is single access, which is the left groin. The Impella is through the left groin. And then, of course,
single access.
Single access.
So single access, as you can show with the top camera.
Catheter.
Right. Okay.
And then through that, you can go with the 6 or 7 French. So that is the advantage. Yeah, that's the advantage of this 14 French.
14 French. Yeah. Okay. Excellent. That's what people. And the other question they have asked is pre-close.
Yes. So you can, the fellows right now, remember they're almost ready for graduation. Another couple of months left. They are able to do pre-course, ultrasound guided pre-close they do, and they're getting access for all large bore by themselves now. Yeah.
And actually that is a part of in the Protect 4. It's a mandatory that you have to have either the aortogram or the vessel runoff or see on the CT scan, and use the ultrasound guided puncture, and then of course using the pre-close, a micro puncture, ultrasounded, and then the pre-close. Yes.
Another question, is an Impella an overkill here?
Well, I mean, the question comes is this: if any case needs it, this is the case.
Okay.
With the ejection fraction. Now, you can say if it is a chronic LV dysfunction, maybe it's not needed. But this patient used to have EF around 28% before, and now it's less than 20. So definitely the event of December hit the ventricle further. So that's the question. Now, some people guide by the EDP, but there is no data. So even Protect 4 trial will be the largest trial of the Impella used, 1200 patient. They are done 1130 now, 70 left. And we, myself, our center and Germany is neck to neck. We are 75, they are 74 in terms of top enrollment of the 110 centers in the country. We, of course, who finishes to the line, we did the first case, and hopefully we want to do the last case, be the top enroller in this Protect 4, which is the trial, a hard endpoint of the death MI, and of course revascularization as the secondary endpoint at 3 years, with the last patient has done the 1 year of follow-up. So even if we finish by July, let's say, the data will not be available before AHA or TCT of next year for the follow-up point of view. So the trial results will be available either end of 2026 or first quarter of 2027. So that's where we are. So as you said, the wire choice, I would have gone with a whisper. Let's find out. Know what you want.
No,
to
I
go
want
with.
to know if they can, if anybody
No, but
can
there's
respond or no.
question.
Anu, to
respond.
answer 15 people watching, and I've already asked them the question.
Okay, let's see.
Okay.
So after I get an answer, I will tell you what's my wire choice.
Okay.
That's one. And other question, going back to that, Impella could be a overkill with this particular LED, the way it looks, right? One, we may need multiple wires to get through it.
Choice is whisper, by the way.
Okay, excellent.
Whisper. Okay.
Then the other thing is there is a risk of developing slow flow with this vessel.
Absolutely.
Yeah, so when that happens, the single vessel, I know there's LV dysfunction already, so just be prepared for that. And RC already has disease. That's why I think protection with Impella would be a good case.
This kind of a AP caudal view you have, a very tricky lesion to cross.
Yeah. But I'll just go with you want over the wire system or side by side only. Okay. You decide. I would have gone just direct whisper anyway. So with that note, let me complete. Yeah.
Other wires have been recommended. Horse wire, the workhorse wire, the Fielder FC, and more choices for whisper.
Good. Whisper is the okay. So let me complete our presentation, and we are ready to see live action. So this is plan for imaging guided protected PCI with the LED and RCA with Impella MCS support. Now I put a imaging basically not as a baseline. In this particular case, I think imaging should be done after your initial work. So if you go to our two vessel disease, this patient has two vessel and and involvement with a no diabetes, proximal LED, appropriate patient with a double calcium blocker, beta blocker as well as nitrates. So makes it appropriate point of view. Okay, Anu, tell us what is you ready to start now. We are go back to the floor. Good. Show the hemodynamic on one side and floor on other side. Okay, very good. Let's go. Go to the same view and we'll magnify there.
So, how much is the augmentation at the moment from the Impella?
Guys, why we don't see the Impella augmentation? 3.3 they're saying.
It's about 3.3, yeah.
All right.
And another advantage of this 9 French devices are because they become 20 to 25 French inside the body. And even the EPS of the Impella group. So even that one also. So all of them will give a bigger cardiac output having a small size. Same thing and all those randomized trials are going to start now.
Show me some dye.
Yeah.
So what wire is this, the whisper?
No. There is a diagonal right there.
Very ulcerated, truly complex. A pretty sharp angle into the LED.
I think don't put the device yet.
Yeah,
just go with the wire alone.
Yeah, that could almost work against you there.
Yeah. Now this is a what FCL guide is this or VL?
This is another mistake we
You
should
may need a
probably
VL
control.
3.0.
Not VL30
or FCL 3.5, FCL 3.5 if necessary. So now it has gone into 1 lumen.
Can you show us the die? Little die.
Want picture or what?
No, some die.
Several questions, I mean, more on the single access Impella and that how easy do you find it?
So what we learn is that the single access is okay as long as it's not a multiple manipulation of the catheter. So if your guide has to go in and sit, it's okay. But we have seen many times interaction of the sheath with your 7 French guide. You can use a 6 French or 7 French, which is not a problem. But many times when manipulation of the guide definitely is a trouble. And we see that if that's the issue, you probably should go with the counterlateral puncture. So new 9 French, all of them will require putting an additional sheath whether radial or
Can
other
you take
side.
a cine?
Okay.
Very complex.
Yeah.
Not
further.
only the entry of the lesion, but then further to keep it away from the dissection plane. Sameen, many more questions on Impella. They've absolutely surprised us, and this should guide us that probably we need to be showing more cases with Impella. Are you using, there are people, including Dr. Nikhil Jha, who's inquired about the wedge pressure and also, further questions whether you're using routine right heart. I don't even think routine. I don't even think you're using it.
Yeah. So 2 points. So question is, as I mentioned already, the EDP. EDP, based on the EDP, use of Impella, in my opinion, very factitious. Why? Because your blood pressure, your EDP may be 12, but you engage into the vessel and vessel goes down, your EDP within seconds will be 30. So EDP, in my opinion, alone should not guide, and that is what, as a part of the steering committee, when we did the PROTECT trial. Now, second point of the, what about understanding of the right heart pressure? So very important. So what has required is that one should do the trial. In the trial, you had to do a right heart pressure, but it's not routine. So there is a group where you need to do in a PROTECT 4 that you identify yourself as a right heart center. So every case right heart will be done, and of course your de-escalation and all the data they are going to collect and tell us that which case did okay with the de-escalation based on the right heart pressure. But do you need it routinely? Answer that is no. Even in PROTECT 4 trial, we are part of the not the right heart cath. Now, other trials, the Picante magic, Picante on our, which will start off the other 9 French magenta, all of them require right heart catheter. So as a baseline, when you're doing a the phase 2 and phase 3 trials, they need to have all the data on the right heart. But do you need it typically? I would say that if you want to do it, you believe in that, is okay. But do you really need it? I would say no, because we do about do about 150.
Excellent job there, and like to know more about your technique and approach there, and
the wire.
We have, and the wire. There were people already suggesting switching to something like even a Gaia here. But that is, I think, way too aggressive. And Anu, what wire? What did you do different? Or did you just lean on 35 years of doing it?
I think 35 years of doing it.
Yeah, just beautiful. I mean, this was as difficult as it gets, because you know that wire you go subintimal, the case is over.
Yeah, it looks like some miracle group of family, right?
Keep guessing, keep guessing. We can put a multiple choice question there.
No, look, I think we'll be less surprised with what wire you use, but your thinking behind it, that and that's precisely the purpose of this session. And Anu, many more questions here. So Sameen, I can actually take you to some This question was actually posed to me by Dr. Imtiaz Ismail from, I had not met him before, or maybe I did. So I asked him where he's from, and he said Sulphur Springs, Texas. And his question is fascinating and very pertinent. And before that, he even made a statement that he's a heavy orbital atherectomy operator, and he wants to know your thoughts on the Eclipse trial.
Okay, very good.
Okay,
So
let's come back to the case here.
No, just let me complete this.
You were not telling us which wire. Yeah. So I was wanting to have people tell us what wire. Then that's why I moved the topic away from you.
Okay.
Yeah, and just to say orbital, I will talk about orbital atherectomy in our presentation. Excellent. So let's keep that for later. Yeah.
Excellent. So Dr. Nikhil Jha mentioned pilot wire.
Okay.
So the choices here have been pilot, Gaia, FC, workhorse wire, and Whisper.
The diag. That's a little funny, right?
The Whisper was the number one wire choice, right?
Yeah. I'm dying now.
But that had been, that strategy was almost abandoned after the first Whisper did not go. Or we don't even know if it was the Whisper, but keen to know the thought process behind this wire.
No, I'm trying to make sure that we are in the lumen. You see that? I'm not able to get into the, okay, now we are good.
There you go. I mean, you had the difficult lesion you were able to cross, and then it doesn't go into the LED, goes to the diagonal. Excellent
that
job
could have
with
been,
the wire.
Yeah, so here, let's go back to the thought process, right? So let's see here. So we go back. This does not tell us. So this, I think this is an angiogram that is telling us that it could be, multiple dissection plane, or there is one channel. You see that in the lower part of the lesion. That is where you have a one fine channel. So could it be coronary dissection, like we said, or is it organized thrombus?
Recanalized.
Yeah, recanalized, organized. Thrombus, okay, whatever, what you can say that. So if you have that fine channel, organized thrombus or recanalized thrombus may be an easier one to cross. But if it is a coronary dissection, you got to make sure you're in the lumen and not in all those dissection plane. That is why my first wire choice was a run through. Okay. So we took the run through. If you see that, I just wanted to go to that lower part, because if you go with any polymer jacketed hydrophilic wire, likelihood that you will go into all this other smaller dissection plane, whatever, would have been higher. But run through was reaching to some point and would not go further. So then you advance your over the wire, means fine cross, which I had. You see that? And this picture is telling us that the guide is not coaxial, it is not facing into the LED.
Right.
So there you have two choices. One, you advance the same guide so that you are getting into the LED, or change to FCL, where you can now just get into the LED straight. We didn't want to change the guide, advance the same guide. Okay. So, and then see, this picture was telling us that something has to be done. This kind of figure of S is not going to give me any help with the tip of the wire, and it is facing into that so-called dissection plane. Now look at this picture, definitely dissection there. So you have to be very, so now you see how I change my guide, advance the guide, right?
Right.
Now we have to make sure that we are in that one fine, there is one fine area where we can go through, and I went to the fielder. That is the fielder. Now, if you guys can tell me, if you are done Whisper, you could have gone straight there, but I didn't want to take the chance. No, regular fielder.
Regular fielder. Okay, that's the answer for the Samir. Many questions. And probably it's not a question actually. I'm going to give you a summary of something like 50 notes I've read from people. Majority of the people, and this looks to be because our audience at the moment is so much more at this present moment, international and from India, people have tended that either no Impella or intra-aortic balloon pump. I think
this is the case. Yeah, cost is the big issue. I would say that in ESCC Jaipur, I'll use this case with the balloon pump. Yeah,
Right.
no question there. Yeah, because remember before Impella,
IVUS.
huh?
IVUS.
You want to IVUS? Oh, wow, high level. They're doing IVUS now. So I would say that before Impella, it came until it shows that the significant difference has not been there. And I know the cardiogenic shock, some data are different, but high risk PCI, I think the data still has to be proven. We know the balloon pump does not work, but do we know Impella works? That will be the Protect 4 trial, where 80% in the control group has a balloon pump and 100% in the Impella group has an Impella. So we'll need to see. So I'm a little skeptical yet till the data comes out of the trial. So till that time, many high risk because of the cost. As I said, this case, without hesitation, we'll do it at ESCC Jaipur using balloon pump, and here it's appropriate to use Impella. Some adjunct device is important because if this LED goes down and we didn't have a chance for do any viability or any studies, but if this LED goes down, EF is already 18%. We could be in trouble. So whole question is that not let's see. I always believe it. No, let's see that maybe that can patient get a rota or not. No, if you're thinking can get a rota, then means you are thinking rota is needed, do rota. Same way, if you thought about, so as I said, if patient has LV thrombus now, or patient has a moderate AI, we would have gone with the balloon pump only, not Impella. But this was a good case for Impella, and that's what I would say the logic behind it. Now, had not been the case today, this is an ideal case for Protect 4. But since the trial case cannot be live telecast, so we did not make this case today. So let's say the live telecast would have come, Protect 4, it would have come with the balloon pump. We'll do this case with the balloon pump.
Completely agree, Samin. I think the entire field is going to totally change in the next few months as we have more LV protection devices. I think the fact that you are now able to move to a shorter 9 French or something close to that, that changes the entire thing. Cost will come down, the sheet size comes down, complications will dramatically reduce. You've got a totally different ball game.
Yeah, absolutely. And the key is that there are 5 Impella type of devices. I have MCS, and we actually at Sinai, probably only center in the world which has used all 5 of them. 4 of them in the trial. And
I mean, are you able to give even a more specific answer? Which out of those do you like, or is it something we should?
No. Magenta. No, Magenta. Very good. Oh, super. Yeah, all the 15, I did 9 cases, but that's the easiest of to be used of all the devices we have used so far.
All right, Kiski time. Anu, why did you use IVUS and not OCT?
No, the region is so tight. We may not get a good flush of the distal vessel.
Got it.
Yeah. So it looked like thrombus, right, Kiski?
Yeah. Or ruptured plaque.
No? You need OCT for that. Yes.
Yeah, that's why my question was more towards OCT for.
Let's listen to him.
Go ahead, please. We are not hearing him.
Yeah, so he did not have it.
Yeah.
Okay, start from the beginning.
Yeah.
Sure. So I start from the left main. Now this is the guide. This is the proximal left main. Lumen is good. Then now I see the circ from the 6 o'clock. So this is exactly osteo LED. Like
show with the arrow. Where's the circ?
Yeah.
Go
this
back.
is the circ.
Okay.
You can see here.
Okay,
so
good.
this is exactly osteo LED. Like a lot of plaque.
And
like
where's the circ?
This is a circ.
Okay.
And this is the osteo LED.
Good.
And 90-degree calcium.
Okay.
Then I go distal. Here, like some irregular lumen. This is lumen. This is like IVUS catheter. So it looks like it's like a dissection, intimal dissection. And the plaque is not that much calcium, mostly fibrous and lipid. Here is a slightly calcium, but mostly fibrous and lipid plaque. And here, the vessel size, the AI detected is like 3.3.
No, let's go to morphology first.
Oh, sure. Anyway, it's not much calcium. A lot of like a dissected lipid and fibrous block.
What is that little, you see that round, is it thrombus? Yes.
Yeah, but it looks like lumen. This is like a same density compared to the iris catheter around iris catheter. So this is a lumen, like irregular lumen. I'm not sure this is a previous one or today's like a wire-based injury or something. But anyway, irregular lumen.
No, it's from previous, but from this can we say it is a coronary dissection?
No, and what is against the ruptured plaque?
Yeah, possible.
Yeah,
anyway, the intima is like disrupted.
Disrupted.
Yeah.
No.
Yeah, medial dissection should not have intimal, more of the medial dissection. I mean, spontaneous coronary dissection. But here, to me, it looks like multiple craters and
multiple dissection planes.
Yeah, great. Yeah, that's a classical feature of the ruptured plaque. Anyway, let's go. There will be more to learn. So now this case, I would give a little verapamil beforehand, or you want to give nipride? Because this case very likely will develop slow flow as soon as you dilate with a balloon. We had 2.512. What is it? You want to give a little nipride before dilatation?
So you pulled the wire back.
Samin, you had asked it, but specifically several people have addressed with this question. Kiski, is there thrombus at the 5 o'clock? That's what Dr. Sharma also asked, but I want you to answer.
If you think this cross section, I don't think so.
Maybe the next one you should do the OCT.
This is a connection to the lumen. This is like an irregular lumen. It's not the thrombus. Thrombus should be more low, like low mass, irregular mass.
Yeah, exactly.
Got it. And Samin, I had missed another question. This is by Dr. Jha. Was there a consideration for a viability study in this patient?
Yeah, very good point. So the question was, the patient was referred for MRI and patient could not lie in the MRI table. Yes, that was the plan originally before this patient was sent to us. They scheduled the patient for MRI, but patient did not tolerate the MRI.
We should do a trial to show how many patients cannot even lie inside.
Yeah, many of them. I would say 1 in 4. Yeah. 1 in 4 comes out. We waste so much time, wait 3 days, go upside down.
If they have a plaque rupture before, they'll have it after the procedure.
Let's take a picture.
Maybe they should get that open MRI. Go. Something like that.
Okay. Looking
a lot of spasm dystocia, but that's okay. Yeah.
So more questions here, Anu.
Go to caudal view.
You planning to address what Kiski found with imaging, the ostium of the LAD?
Yes.
Yeah, no, ostium.
Our stent will come up to the ostium. Yes.
Yep. Stent has to come to the ostium. And only jeopardize is there is a small diagonal there or medium size. Good. Let's take this out.
Okay.
This vessel has to pump up. Yeah. 3O?
Yeah.
3O23?
Yes. No. Long. No. Up to the diag.
28. Okay.
Come up
No, but before the diag. 28.
No, I would go longer. 33 at least. 33. Ostium to there.
Did you use any intracoronary vasodilator?
Yes, we did.
Nipride.
Nipride was given.
Okay. The magic drug.
Yeah. Good. So you want to go to which view?
Yeah. No, I want to see here the length.
Okay. So I'll tell you length. No, 1 second. Length will be shown in this view.
I thought it would be foreshortened there. Yeah.
This one is good. Yeah. RAO caudal. Yeah. Okay. Let's go.
Samin, another fascinating question.
Cine, we'll do cine. Yeah, see, this is the best view.
Okay, here we go. That dissection plane is still...
A minimum 33.
33, good. 3033 Zines, Yeah, what is the another question?
Again, Dr. Nikhil Jha, will we consider device therapy in this patient?
Yeah, so no, that's absolutely, that's a clear indication. So only question is, patient, the initial, ideally patient waited 3 months, could have got a device beforehand. As I said, since patient was on the path. Yeah, that's okay.
You got it?
Yeah, I know. Good. Patient on the path of getting the PCI, they did not put the device, but this case should have had a device at 3 months because this is already the 4th month now.
But once you revascularize, you need to wait.
No, I know, but question is, could this patient could have a device even beforehand, since no PCI was done? So you are right. That's the point. Yes. So point is now we will decide. Now we have to wait for 10 weeks, after revascularization to see if the EF does not improve more than 30. If less than 30, gets the device. Yes, that's a clear-cut, life-saving device, even bigger than your PCI. Want to magnify?
No, I want to go to the caudal view.
So Anu, another question for you.
Yeah.
Would you consider wiring the circumflex?
No.
Okay.
Take a picture.
Hold on 1 second. Let us just bring this like this. Yes.
Right side, your carry guide or Lima guide?
I think Lima, right?
Okay.
I'm bringing it closer. Yeah.
Or
Good.
RPT.
Okay. Good.
Ready?
Good.
Yeah. Sine.
Radiation protection therapy.
Yeah. Good. Very good. Go up, right?
Okay, go up. Yeah.
Yeah. Will be okay.
That's a 3.5?
3-0.
No, 3-0.
3.0.
3-0-33.
I was
Yeah.
ready.
Yeah. Based on the IVUS sizing.
Yeah.
Okay, down.
Yep.
No, this was EYE sizing.
The only question is that this one may occlude, not occlude, cover.
Yeah, you cover the
your
diagonal.
second diagonal. Yeah.
Yes, yes.
Second
That's okay.
diagonal, but that's okay. No harm because that second diagonal has no disease. Good size, no problem.
Right?
Yep.
Okay, Columac. I guess. Just making sure.
Okay, actually it was not,
Just
it did not
there,
cover,
you see?
just there. Very good. Okay.
We are.
Now
This
you want
is-
to post dilate? or-
EY. Yeah, this is EYE.
Are you going to do something to the midsection or leave it?
No, I think leave it alone. We never
that
went
you
there.
leave it alone, yeah. That
So
will
they were-
develop flow-mediated vasodilatation. Vessel will grow up and we can post dilate with a 3.25. What was the vessel size?
Proximal LAD is 3.5, but mid part
we
is
can
3
go
The
to
3.25 is good. 3.25 balloon,
Yeah,
right?
3.25, 20 you want?
Yeah.
15.
15. Yeah, 15.
Okay, once we do that, then we will give more vasodilators
And then
take
we
a
go to
final
the right
picture.
side, yeah.
Because we want to show now at the end, no, we have to do IVUS. So
Yep.
you'll know that
Good.
the stent placement was
Perfect.
perfect.
Yeah.
EYE confirmed stent placement.
Are they done other side or what? They're doing it. Okay.
You're holding.
Yep. Good. Connect.
How much is the magenta going to be priced at?
Yeah, so right now is the price is the same.
Go.
$25,000 they had. Question is, what are they? I'm telling them, make it 20,000. So I'm suggesting that. 20,000 should be the right one. So when the trial will start, because we're not ready yet, the FDA has given the green light, will be against Impella, and so they will make it at 20,000.
I think the real surprise may come from Johnson & Johnson. They did not acquire Abiomed just for the existing device. I think there may be many enhancements they could be having in store.
No, they actually, coming back to the
probably
point,
wait-
very important.
Right.
The first 9 French will be the ECP of Impella, which was already studied. We did only one case. Yeah, let's take a picture. What do you do? Or I was. Okay. So we did first case only, and after that, since I became PI of the Magenta, they said, no, we need to get with them that time. Yeah. So from FDA point of view, so we did. So ECP likely will be available in third quarter of this year. But they have finished their trial, randomization. So, I mean, it was not a randomization. It was just because it was the same device in the sense, of course, the size difference. So the FDA didn't require randomization. So that's one. ECP will be the first one to be available. 9 French.
Destroy the IVUS.
Yeah. Why?
Get the other wire.
No.
Sameen and
I'll
Anu
tell you.
flooded with questions and comments. Let me bring some of those to you.
Yeah.
First of all, I polled the people which agent do they prefer, verapamil or nitroprusside. Almost all of them
Run
like
through, you have?
nitroprusside. And there is also an audience request, which is which is that they would like to see the lesion be interrogated with the OCT for the final picture.
What will, after stenting, what will you learn?
I am
Nothing.
just reading it as I read it, Anu. I cannot read their mind. But then there is a fascinating question that assuming you were looking at SCAD, what modality is better, IVUS or OCT?
I mean, see, in the very early part, SCAD, they used to say probably OCT is better, but then subsequent, the guidelines all are saying you should not, because you can actually make it worse.
Yeah.
So that is what I used to once upon we actually have papers of us with SCAD papers with imaging, but now I don't anymore. It's not recommended.
Because of making it worse.
Yes. Okay, give it to me.
I think so. IVUS is enough to see the hematoma, so and a deeper penetration. So IVUS is good for detecting the SCAD.
What does Kiski say? IVUS is good enough?
Yeah, to see the hematoma.
Okay.
And a good penetration. OCT is like a shorter penetration.
Okay.
Let's ask Kiski. After stenting, is it going to help us, OCT?
If we want like a detail like a plaque protrusion or something, you can. But for
or more importantly, as dissection. I think that will be the only one in this case which is prone to dissected vessel anyway. So, I mean, I can tell you, I know the audience wanted. I probably, I'm not a big imaging guy, but I think I like to see it on OCT. But will it change anything? No, I think it's an intellectual curiosity. That's it. But we'll see. Because I think, but we need to do the RCA also.
Okay, show us the distal edge now.
Okay, check the image.
Imaging.
Okay, it's a native. Okay, start pullback. It's coming. Pullback speed 4. Looks okay, like a no big hematoma or something. And the stent is expanded. Nice. Here's eccentric. Yeah, I will stop it.
Okay.
Forget OCT. We do the RCA.
Final picture.
Verdict.
Yeah. Of course, it's a. I mean, there is no good landing zone, so distal edge is on the plaque. But I don't see any flap or hematoma. I think it's on the plaque, but looks like no dissection.
And did the stent come to the ostial LED? That's the key.
It's exactly at the ostial LED. Once strut is out, which is what we wanted, because it was ostial LED.
This is the exact proximal edge of the stent, and then you see the blanch. So at the level of the bifurcation, but not much stick to the left main.
Yes.
Beautiful. Good. Go to the RCA now.
Okay.
And
right?
Yeah, MSA is like 5.5, so it's an optimal result.
Samin, many questions more.
Okay.
Going to read this one by Dr. Mahmood El Rais, who's been a devoted participant. I'm going to read his question exactly as he put it, because that would reflect his thinking. In case of suspicion of SCAD, is there difference to inject contrast in proximal or mid to distal dissection?
Well, I would say that don't inject in the dissection, just do a proximal and don't do with a pressure injector.
Okay.
Definitely no pressure injector, yes.
Dr. Rayidi Gopi Krishna, can we use bivascular scaffold in SCAD?
Yeah, if it's available, yes. Particularly in India, Miras 100, yes. That's a good case. It will be a good case. But if availability, and I still need to see that how the Miras 100 points out. I know the very good data available in India at this time, but they're using it, and I can tell you I did have use some cases, but one case I had a very bad experience that I had 2 acute thrombosis of I put for ISRs, which were done about 20 years ago, and this is about 2 years ago at ESCC. I put a Miras 100 in both of them, and patient thrombosed 2 hours later. Both. So since then I'm not using it, but yes, a lot of people are using the bivascular, BVS in those cases. Miras 100 is 100 micron, and whether it will make it to the guidelines or whether it will come to America, I know it's being used in many other countries. Not only India, in Brazil and many other countries, it's available, useful. I do not know if it's a CE mark approved, but I know that many countries in Arabs and South America, it is being used.
I think
Miras
it
100,
is.
yeah.
I think it is CE approved.
Okay.
Here is Anu. This is exactly the answer you were kind of giving. It's just that Dr. Anand Palakshachar. I hope I have pronounced your name correctly, Anand. Contrast volume will be much more in OCT for EF of 18%.
Yeah.
Straightforward reason. Absolutely right, Anand. And glad to have you join us.
Okay, so tell us what the strategy, so I can go with some slides.
Okay, so we will. I think we'll do single wire.
Yeah.
We'll get into the PDA, dilate it, cut it, and then short stent in the ostium and another stent in that mid RCA.
Okay, so 2.5.
I was the mid RCA.
Okay.
So Kiski can show us some, because right now I think also since every imaging is become very important, people want to learn, we can show what does it look like there, right?
And the counterpoint has been Samin offered by Dr. Nikhil Jha. Now it's saline OCT, no contrast.
Yeah, I know. I mean, we had to.
OCT has a lot of issues. One, it's not, visualization is not the best. Still, there is a risk of, arrhythmias.
It's still there. Yeah. But one thing for sure, what people are using, Guideliner or Godzilla, put it there and just inject 2 cc's of contrast. So limit the dye. So a lot of things are going on with the OCT, but I think while they are doing very good in terms of their algorithms compared to the IVUS, but the contrast, they still had to come up with a better solution for the contrast yet.
And audience looking ahead, they are talking 2.5 cutting balloon.
Yes, that's exactly we have. All right, so while they're getting this little routine for us, so we go our presentation. So we'll catch up as Anu does the cutting balloon and bring it there. So why this is cut off, guys?
No, but when you're doing it, they won't see the procedure.
No, but little cutting balloons, they don't want to worry about cutting.
Okay.
No, but let them see. Okay.
Fine. Keep going.
No, but as soon as you're ready, yeah, good. Okay. So what I'm going to talk about is, the interventional trials were very few. Coronary interventional trial in ACC. There are a lot of structural trial, lot of general cardiology trial and EP trials. Heart failure trials. EP also very little. So I'm going to show 4 trials this month and 4 trials next month. And there were many of them were kind of a more recycled than truly. Smart Choice 3, FAME 3 5 years data, Extrom, which is colchicine and Eclipse intravascular imaging subarm or sub analysis. Then there is a whole issue going on with the angina symptoms verification and PCI efficacy. Remember on the Orbiter group, they are the one who did a placebo control, PCI versus no PCI, which showed the angina relief better with the PCI compared to no PCI. And then now they said, is the symptom which patient getting? Is it because of the lesion? And so what they did is they put a balloon into the area of the lesion and then try to duplicate or replicate their angina symptoms. So that was N of 1, trial of angina verification and symptoms as a predictor of placebo control efficacy of PCI Orbiter 2 trial. So with that note, let me go quickly. The Smart Choice 3. What was the Smart Choice 3? It was a trial from South Korea. Patients have completed their depth duration, whether 6 months or 18 months, and then were randomized to aspirin or clopidogrel, just like a host exam 3. So this is a basically trial of the 5,000 plus cases, and these patients have been and these were also high risk for recurrent ischemic event, which is defined as previous MI, diabetic, and patient has complex PCI. And we know the complex PCI basically include bifurcation, lesion length, left main, and so on and so forth. So, and these patients were followed, and as you can see, up to 3 years of follow-up. Basically what it shows is primary endpoint was significantly reduced in the patients with the clopidogrel compared to aspirin. Then myocardial infarction also significantly reduced, and there was a trend towards lower mortality. The stroke was no different, and if you go to bleeding, there was basically no difference in bleeding. So what we learned that giving clopidogrel is better than aspirin after the maintenance therapy. So this is a little different. You can think about the Capri trial after 18 months or 12 months of PCI and showing the clopidogrel better than aspirin. So this basically was the message. Individual endpoints are shown here, and they actually went through the diabetic patients. On diabetic got a little more benefit, acute coronary syndrome a little more benefit, and complexity of the PCI more benefit, and so as shown here. Bleeding was fine, but then other one is very interesting observation which we all knew, but first time the gastroesophageal reflux disease and GI clinical event all were significantly lower in clopidogrel. Bleeding was lower but did not make a statistical significance. So just to say, anybody who cannot tolerate antiplatelet therapy of aspirin, clopidogrel is a better choice. So this is what we learned from the trial. And this basically was the conclusion of the trial monotherapy. Then second trial was the FAME3. The FAME3, you remember that FAME3 was the 3-vessel disease trial, FFR guided PCI versus CABG in those patients. And at 1 year, there was clear-cut benefit of CABG over PCI, particularly intermediate to high syntax score. And in the 3-year data was still the hard endpoints, or p-value was 0.08, which I showed 2 years ago. And now they showed the 5-year data. And I can tell you that the trial data really brought a smile to a lot of interventionalists. This was a clearly multi-center trial published in Lancet, and these are the individual endpoints. Antiplatelet agent, statin, beta blocker, all very strongly continued, very high and very interesting. And look at here, at landmark analysis, at 1 year is different. After 1 year, curves almost overlaps. So at 5 year, the death, stroke, or MI, no difference compared to in between the two arms. So very, very interesting. And these are the endpoint, 16 versus 14%. MI, yes, lower MI and lower revascularization. Stroke was higher, but did not make a statistical significance. So what does that mean? If you think the patient going to live 5 years, it's reasonable to do a PCI versus CABG, and that was the many editorials. And it was some relationship with the syntax score, but was kind of very haphazard. You see that the benefit was more in the low risk, but in the intermediate risk and the high risk is kind of overlapping. So this basically what we have in this particular case. So now, so that's basically the trial data, the FAME3 5-year PCI. Then we say, well, okay, there is another major trial which have been done on this field, which is the syntax. So syntax was done about 10 years ago, and now the FAME. Look at the event rate. Mortality, which was in the trial, both 9.2 in the CABG and 14.5 in the PCI group, was 7% in this current era. So tells you 3-vessel cohort, the kind of matched, a little bit different in terms of syntax score. You can see here more acute presentation, diabetic even a little more. So it's just basically telling you that how our interventional combined, not only just the procedure, and of course, the overall care of the patient has led to such a great outcome with the risk factor reduction. Same thing for the death, stroke, or MI. The event rate, which used to be 14% for the CABG, now it is 14% for kind of both PCI and CABG and so. So big difference that we have made a big improvement in reducing our event rate in the PCI group and compared to the CABG, which remain identical. Then Ekstrom trial, the colchicine is not going away, came back. They did a progression of the plaque progression of using the colchicine. We know the colchicine data, very good old trials which combine, that is inhibit the inflammatory activation, then inhibit neutrophil chemotaxis, adhesion and activation, and basically works on the tubule and decrease the tubular replication. So this has been inhibiting neutrophil platelet interaction, has shown decreasing MI, stroke, revascularization, no difference in death, although slightly higher infection. That has been overall trials which have shown 4.2% event in the colchicine group, 5.7 combining all patient with acute coronary syndrome as well as stable CAD. Then we showed that trial last year, about a few months ago, clear synergy, OASIS, where patient with post-MI, STEMI who got a PCI, started on colchicine, there was no difference at 5-year follow-up, rather there was more effect, more trouble. So basically the concept of the colchicine is that it does decrease the plaque progression. This has been from the lab data. As you can see, control versus treatment, low attenuated plaque is decreased in patients, significantly decreased in the colchicine group, and that led to this trial called XTROM, where about 100 patients, colchicine versus placebo, and had a follow-up plaque volume atheroma. So the low attenuated plaque, no difference. Total plaque burden lower, but look at the non-calcific, fibrofatty, fibrous plaque, all were lower in the significantly reduced in a group with the colchicine, and also the dense calcific plaque progression was less in the colchicine, significantly less compared to the control group. So basically, plaque point of view did good, and this is the CRP measurement significantly reduced in the colchicine group. So CRP value. So basically this actually puts it together that we have a no difference in low attenuation plaque, but the plaque volume decreased by 1.1%. Now what does it mean? Studies have shown that once you decrease 1% of the plaque, you decrease 25% of the event rate, which is from earlier Colcott Lodoco 2 trials. And this actually shown that you see the 1% decrease, minus 1%, decrease the event rate by 25% MACE at follow-up to these patients. So therefore it may translate, but this trial did not show that because it was more of a imaging trial, and it has a beneficial effect on the plaque, and of course lower C-reactive protein, but we need to see what will be the long-term outcome, because we know the post-MI, the last trial, clear synergy showed no. But what about patient with the stable coronary artery disease or complex disease, which will not know? So as you know that from the guideline point of view, it's a 2B indication by both European Society of Cardiology 2 years ago, and the recent our ACC-AHA still remain 2B. Now I do not think it's going to go up based on the clear synergy, which is the largest trial. And of course, we know that there are contraindications for it in the renal liver dysfunction and patients who are taking CYP3A4. So then the last trial, which is what I want to talk, impact of intravascular imaging, IVI, on guidance of PCI in the ECLIPSE trial. Remember, ECLIPSE trial was the trial of a calcific lesion randomized to OA or balloon angioplasty followed by DES. And then within the each arm, there was IVI guidance or angiographic guidance. It's about 2/3, 1/3 in both the groups. So 2/3 of the 2/3, like 70% got the OCT, or 75% and 25% got the IVIS. And this is basically the data. Overall, post-stent, lumen got a little better in the intravascular guidance, which we expected. As you can see here, and so on and so forth, patient level target lesion, what you usually expect, that patients with the intravascular imaging, more fluoroscopy time, more contrast, because predominantly it was the OCT in these cases, and of course the procedure time was higher. And this is a definite, basically the trial outcomes. The angiographic guidance event rate was 13.2%, which decreased to 9.3 in intravascular imaging guidance, whether OA or BA was shown on the right side. So just to say, the imaging interaction was very significant, even adjusted or unadjusted odd ratio of less than 0.03. So imaging with calcific lesion. So this is where, as you see on the right side, independent of OA or balloon angioplasty, it was imaging had a significant benefit. And these are the individual endpoints shown here. And of course, the TVR, even death, and so has decreased, and including the TLR. Now, the question comes is, the OCT versus IVIS. As you can see here, that OCT was much higher than the IVIS group in about 30%, and definition, the OCT did a better outcome within imaging compared to IVIS guidance. So this is what we learned from this trial. So what we learned is that intravascular imaging, 9.3% outcome at the 12 months compared to angiographic 13.2, reduction of 26%, p-value of 0.03. Second point, that we did get if you just go with the orbital atherectomy, there was a better lumen, about 0.31, little better lumen with the MSA stent area compared to balloon angioplasty, but there was no difference in TVF. And remember, this is the story in all atherectomy. All the rotational atherectomy are shown. Better lumen, but higher late loss. And this is what basically remain, that you gain more and you lose further. And I know there were some complications and so. With that note, I'll stop here. Anute, should we go to you now?
There of the mid RCA. So based on the EYE IVUS, I'm taking a 3 to 528, and Kiski tell us mid RCA, then I'll show what we did to the distal.
First, it's like an intermediate lesion, but tightest part is definitely tight, like MLA is 1.5, like almost concentric lipid-rich plaque.
Yeah.
Yeah, and a vessel size, this is a reference based on the this AI. It's like a 3.7 vessel, but lumen is like a 2.8.
Yeah.
So I think 3.25 is like a good one, recommended one, so, because one size up of the lumen. And the lesion length, the minimum length is like a 22 if you want to cover these two tandem lesions.
We're taking a 28. Okay. Now there is, listen, you said it's a lipid-rich plaque, and guess what? We IVUSed and we have some, show some little ST elevations there. Yeah.
Yeah, might be some
Okay,
distal
show me some
embolization.
so we go up quickly. Then I'll show what we did. Okay, now some dye. Some dye, yeah.
Go up.
Yes, go up now. Yeah. 14, 16.
Yeah, these are exactly what we anticipated and the reason to have the Impella.
Yeah, that's correct. Yes.
And these are the unforeseen events happen when the EF is so significantly impaired.
Yeah, actually very interesting. The part, remember, original Protect 2 trial showed that they had a higher complication with the rotational atherectomy group compared to the non-rotational atherectomy, but those were the more complex lesion, high syntaxis score, and so on and so forth. So we did our analysis and we did publish in the Interventional Cardiology Journal. So we did not find any difference in the rotational atherectomy Impella versus no rotational atherectomy Impella, although there was a little different than the Protect 2 trial. Very interesting. We thought that there will be a lower slow flow, and slow flow, although was low, was 1.8% in both the arms. So Impella did not decrease the slow flow, which was already low. I'm sure if it would have been 4%, might have shown the difference, but in our data, we did not see any difference of the Impella decreasing the slow flow.
So, I mean, three important trials you reviewed, FAME3, the colchicine trial, and Eclipse, all important, but none of the results were unsurprising.
Yeah, that is correct. So I would say that, no, but I think FAME3, yeah. I mean, FAME3 in the sense that in the syntax trial, even up to 10 years, the benefit of CABG versus PCI Texas DES remained in terms of those hard endpoint. But here we lost within 5. At the same time, we did not lose at 1 year in the syntax trial, but we lost 1 year in the FAME trial.
Did FAME include left main, or is
no,
it
left
just,
main excluded?
Okay.
No, excluded. Okay. So therefore, was the analysis which I showed you was the syntax trial 3 vessel CAD group only. Because
Nikhil, this was your question. I hope you got that answer. There is also some speculation asking an expert such as you, what do you think was the reason orbital underperformed? Just the mechanistic, or there is something else going on?
The very good point. So I would say that very effective device. No question on that point. Our early data of the 20 cases of OCT we showed, it caused very deep cuts. Second, 120,000 RPM, deadly in my opinion. And that was used in about 22% of cases in the trial. And many of them was start with 120. And some of them were 80, then went to 120. So to me, 120 should be banned. And that's why they had a higher perforation. But although trend towards, but p-value clearly 1% higher perforation, 0.8 versus 1.8. Then the slow flow, and the slow flow occurred more. So I think bigger the burr you use, or sorry, high speed, you're going to create a more more slow flow, and so I think a lot of procedural issues underperformed overall outcome.
This is today's stent. Yeah, looks good. It looks smooth. Good expansion.
Let's finish this, then we'll come back to that point. Yeah.
Some protrusion. Yeah, it looks good. I will stop it.
Okay. Where are we now? Yeah.
MS is good.
uniform appreciation for your skills. Many people have mentioned this was not an easy case, and particularly the LAD.
Thank you. I will show you what we did, and then I'm going to give you my opinion about our Eclipse.
Samin also would like to welcome Dr. Erdogan Yassar from Turkey. He's the new follower, and he says he keeps watching your cases, Anu, you and Samin, on the internet. And I think he's talking about not just the CCC Live, but several others. There's a flurry of cases coming from Mount Sinai, including on structural and peripheral, which I hope the audience follows.
And
okay, Kiski, can we just show the IVUS?
Yeah, so today's stand, I will just show the distal edge, like very smooth transition, no malapposition, no dissection. And a proximal edge is also smooth transition. It's on the mild plaque, but no malapposition, no dissection. Actually, the tightest part is 5.2. It's more than 5. It's optimal because a lot of lipid plaque behind stand. If you want, you can dilate more, but a lot of lipid plaques, it might cause embolization. So it's up to the doctor. But MSA is 5.2 in the mid RCA.
okay.
No, if we dilate, we may get more slow flow.
Yeah.
And
So
already
since 5.2 and angiographically looks good, so let me quickly go through it. So this is where we are, where we showed that significant osteal disease of this one. Now, if somebody asks me, will you wire the main RCA? I would say no. So we went there. Now, if someone says, no, I want to wire it and keep that's the right thing to do. And this is after the 2-5 cutter, we went up to 16, 18, 3 cuts, and we pulled back. This is not where it is, see there, right at the ostium. And this is why I call this the Hitchcock's window, where you see that the radiation is just focused, and you can focus on exact osteal placement. And we do have what we expected, but then quickly wire. This is the fielder wire, and when you're wiring it, you got to make sure you're not going through the cell of the stent. Okay, you should be able to see that. See that we went behind. And how do we know that? We did not go through a single strut of the cell that is your balloon. This is a 2-5 balloon, and see, it went easily. So if you have any resistance with the balloon going through, then you know that you have gone through the one cell of that sticking in the main vessel. In that situation, you have to pull back and rewire it. So we did this, and then this is a picture there. That was a low pressure, 6 atmosphere, looks good. And then we did the direct stenting. Like I said, we use a EYE estimation 32528. This was at 14 atmospheres, and this is where we are, final result.
Absolutely outstanding results. Anu, question for you as well as for Kiski. I'm going to read it as it is from Dr. Gopi Krishna. What are the ideal IVUS criteria for stent optimization with regard to distal and proximal vessel diameter?
So we just have a data for non-left main. It's going to be more than, should be 5.0 based on the ultimate trial. Should be more than 5.5 based on the European consensus. We just have that data. We don't have the data distal or proximal. So based on the data, we just have left main or non-left main.
So I think if you're just going with the vessel size, so there's a lot of disparity, your distal segment should be at least 100% of your stent. Your MSA should be similar to your distal vessel. Proximal, you could have 80. So remember, many of the mean of the 80% average stent expansion is defined. Optimal stent expansion is 80% of the vessel diameter, which is combined proximal and mid. There are a lot of other definitions, but simply. So you try to now, in the absolute value, particularly what has been shown, we used to have a 6.5 for the LAD, 5.5 for the circumflex, and of course 8.5 plus for the left main. So that is where you do now. We know that you can get that, but sometimes it is a cost. Sometimes cost is a perforation, sometimes cost is like a soft plaque. You can do it more, but you'll definitely going to give rise to a more slow flow. So that I would say that as long as it's not a grossly undersized and unopposed, it's okay to leave a little bit here and there, because 0.1 or 0.2% not going to make a difference. What is going to make a difference, it is 5.5 versus 4.5. No?
Dr. L. Rice, does Eclipse trial mean that we should start with balloon and balloon crossable calcified lesions?
Okay, letting go back to Eclipse, let's put an end to this Eclipse question. So let us see what was the enrollment criteria. So in that, the criteria was very clear. If the operator thought that the person needed a atherectomy, patients were not included. That itself tells us that severe calcific lesion was probably not included. So likely moderate calcific lesion was included, and in the imaging part, that's what probably it showed. Now going back, you asked that question, was it mechanistic? It's 100% mechanistic, because we have shown it multiple times in orbital atherectomy. How does orbital atherectomy work? That you need severe calcium, that is at least 3 quadrants or 4 quadrants of calcium, because it orbits, it goes round. Okay, if you have, that is what our imaging paper that have first shown, that if you have only 1 quadrant or 2 quadrant calcium, the so-called normal vessel. See, in rota, there is that physics theory where it deflects. We never saw that deflection. It cuts through the so-called normal looking, and we saw deep cuts, and that is why we did see perforation as well as slow flow in these cases. So going back to the point, it is mechanistic. Probably moderate calcific lesions were included in the trial, because you got to make sure you are comparing it to balloon. Okay, so uncrossable lesions were not included in the trial.
Anu and Samin, pause your thoughts here for a moment. I've got something quite amazing. Anu, are you listening?
Yes.
Okay, this is, I'm going to read it exactly as it is, 2 quotations from Dr. Imtiaz Ismail first. Superb results. Dr. Kinney's wiring skill is something that is next level. God-given gift. If I ever need a procedure on me, I'll come and find Dr. Kinney. Wow. What better compliment could there ever be, Anu?
Thank you.
Samin, this is from Dr. Gopi Krishna. We are very fortunate to learn from legends.
Yeah, and coming back to the point, we still have to complete our second part. So rotational atherectomy, the inventor David Oth. So when we did the case, 1994, I had the all complex cases. First 5 Reisman came to do a proctor, and by looking at the cases, he had to sit down on the chair. I said, "You are telling me that these cases you want to do as a proctor?" I said, "Of course, simple. I finish it myself with a complex balloon angioplasty." So then about 8 months later, David Oth came, because he learned that the Sinai is the one which is doing a very complex atherectomy. So he was in the room. Also, we are doing a case, LAD, and patient develops slow flow and goes into multiple V-TAC and V-fib. Of course, with our technique, we revive the patient not even intubated, and patient did fine, comes out of the lab. And he said, you know what, if I'm going around, if I ever had any heart problem, I'm coming to Mount Sinai, I'm not going anywhere else. Even I had to pay the 911 ambulance company to bring you to Sinai. So just coming back to the point that yes, so one point is that these all techniques are procedure dependent. So what I would say, in the Eclipse trial, did they really get the operators who were senior or not senior or experienced? Like, the DK crush, they have clear criteria. You have done 150 PCIs, you have done about 50 left mains or 12 left mains per year, many of those criteria which they have set forth. So the question was that maybe these were not the much experienced operators. There were maybe some of them were one and some of them maybe just newcomers. Second is that whole concept which is percolated after the orbital atherectomy, that you do a balloon angioplasty, and when your balloon angioplasty does not work, use orbital atherectomy. But hello, that orbital atherectomy created trouble. You had a higher complication rate. We had the Rotexas trial, we had the prepare calcium with the rotational atherectomy, we did not have higher complication. So this strategy with RCA RPDA and other people are going through, that we do a balloon angioplasty. No, this is a word basically going on, that what we learned after the Eclipse trial, do the balloon angioplasty, and this is going onto the internet quite a bit. That try the balloon fails, use the orbital atherectomy. But I said wrong message. because that technique gave rise to more complication of atherectomy. So very simple. So that's to our goal should be go approach the right strategy, which will give rise to a lower complication. So that's, I would say, the different statement that if you are severely calcified, select the atherectomy to begin with. Yes, some of them you can do it without atherectomy, we know that. But if you do this kind of strategy, you'll have higher complications. So this should not be taught. So I am very much against that statement which is percolating in the media that based on the Eclipse trial, main conclusion is if the balloon, start with the balloon does not work with the orbital, but that technique caused more complication. There was no difference in TVF despite getting the lumen. So the no, that statement point of view. So question comes is that should you be using orbital atherectomy or rotational? I think both devices are good, will continue, and lot will be in the future to come because the Abbott, which has taken over the orbital atherectomy, want to put a lot of resources and come up with some more imaging and some selected cases, some small trials and so, which will really put the use of orbital atherectomy or international practice. As you know, before to last year beginning, we do about 65, about 70 atherectomies per month, and rotational atherectomy is about 60, 80, 85%, and orbital used to be 15, 20%. But since last November, our orbital atherectomy use has become less than 5%. So which case would you use it? Maybe a very large vessel, you want to go to higher speed and so on and so forth. So limited. But that's where we are. But orbital atherectomy will have a tough time, I can tell you, in the interventional scenario. Everybody felt it has a low complication, it's easy to use, and I think the Eclipse trial told us that may not be the right statement. So with that note, let me complete our the last part of the basically. Actually, let me go back here. So remember, I said the angina verification. That is the symptoms whether truly caused by the lesion. And there are two trials on this aspect of the Orbiter 2 and N1. So basically learn from the Orbiter 2 trials, the symptoms, the predictor, those who are symptomatic, with the PCI, they get the benefit. And symptoms do not correlate with the disease severity, but basically the symptoms predict the subsequent improvement with the PCI that has been shown by Orbiter 2 trial. So second trial, which was very, I would say, gutsy, that N of 1 trial of angina verification. What they said, patient have symptoms, and what if we put a balloon in that lesion, moderate pressure, and then ask the patient to grade, and then also do a fake balloon called placebo inflation, there's no inflation, and ask them the symptoms. So this was a trial, very complex trial called Orbiter Star. And this was the same placebo-controlled balloon inflation. They made the noise outside, and as if all the balloon remain in the guide catheter, punctured everyone, and that if the angina symptoms came as the similarity versus low similarity, they call it a high similarity and low similarity. And what basically they learned, what we learned is once your high similarity score, that's where you get the symptom improvement following PCI. As you can see here, remember the advanced symptoms, episode of angina disappears in those patients where there was a high similarity. So many of the pain which we get is not the ischemic pain. It is some pain for some other region, and this is what we learned, that higher similarity score, those are the patients get a symptomatic improvement with the PCI. And with that note, I'll complete my presentations. Basically, what we learned, clopidogrel versus aspirin monotherapy 1 year after high-risk PCI, very good. FFR-guided PCI versus CABG in 3-vessel CAD for MACE at 5 years, equal, except CABG versus FFR guided PCI for MI and repeat revascularization at 5 years. CABG was better. And then plaque volume change after colchicine versus placebo at 1 year. Yes. And then lastly, IV imaging as angio guided PCI for MACE decrease in calcific lesion at 1 year. So imaging decrease the event by 26%. Not the orbital atherectomy. Orbital and the balloon angioplasty, the outcomes were identical. Was actually few percent higher in the orbital, but we basically showed the imaging added. So key is that orbital with imaging really give a better results, more so when they use with the OCT. Then the placebo-controlled systematically done studies have shown the correlation of angina symptom severity and efficacy of PCI. Symptom severity poorly correlated with disease severity, but powerful predicted efficacy of PCI. Also, similarity score corresponding to angina symptoms is strongly predicted symptomatic improvement from PCI. Therefore, symptom-based personalization of maximum therapeutic benefit of PCI for stable CAD can identify patients who will benefit from PCI versus who will have futile revascularization. Only question is, if many of them require invasive assessment, and where is the ischemia guided PCI? We know the ischemia trial was negative. So I think what is we are learning is the PCI should be beneficial to patients who are symptoms, not necessarily ischemia. So let me go to 3 questions quickly. Following statements are true regarding the Smart Choice 3 trial comparing clopidogrel versus aspirin monotherapy after 1 year of DAPT, except significantly lower MACI with clopidogrel, lower deaths in clopidogrel group, similar strokes in clopidogrel group, lower major bleeding in clopidogrel group, and lower MI in clopidogrel group. Remember, the bleeding was identical, so wrong statement is D. There was no difference in major bleeding. Second question, following are the true outcome in FAME3 trial comparing FFR guided versus CABG for 3 vessel disease at 5 years, except similar primary endpoints of death, MI, and stroke, similar death rates between 2 groups, similar stroke rates between 2 groups, lower endpoints of death, MI, stroke, and repeat revascularization in CABG versus PCI, and similar MI rates between 2 groups. No. So clearly E, there was a lower MI rate in the CABG group compared to the PCI. The last question, following is the false statement in the Ekstrom trial comparing colchicine versus placebo in the plaque progression stable CAD at 1 year. Colchicine did not reduce low attenuated plaque versus placebo. Colchicine did not significantly reduce total plaque volume versus placebo. Colchicine group showed regression of the non-calcific plaque. Colchicine group showed significant reduction in the CRP versus placebo, and colchicine group significantly slowed progression of dense calcium progression versus placebo. And we know that answer is B. There were clearly the total plaque volume decreased significantly with the colchicine versus placebo, although the primary endpoint was the LAP, low attenuated plaque, because that was almost gone in both the groups anyway. With that note, I complete my presentation.
Samin, absolutely amazing. Anu, great case, multi-vessel Impella insertion. Samin, a comprehensive review of so many topics, all done by in 1 hour and 20 minutes. Absolutely astounding. The ultimate, the Orbita Star, quick small comment on you. It's the ultimate sham test you could have. Yeah, but ultimate, if you're trying to figure out, you know, whether the symptoms are coming, this is exactly, it's got AI written all over it, and I bet you the answer will come. Anu, final comments from you. Of course, you must be glowing today with the kind of accolades which you got. To me, the whole case was about crossing the LAD lesion with the wire, and of course the use of Impella. Samin, there was also a question: where would you remove the Impella and when?
Yeah, so that's what I was going to show you. Yeah. Our 2 fellows here, and Manish, come, Manish. Manish actually is our hemodynamic fellow. We have a fellowship for hemodynamic, which is doing mostly
is he the fellow of the month whose pictures are all over?
Yeah, yeah, fellow of the month. Yeah, so he was actually helping, but we can focus on the groin.
Ceiling there.
Ceiling camera to the groin. You don't need to show us.
Yeah, here we go.
Yes.
Yeah, look at that. Look at that. Like nothing happened. Like nothing happened.
Pre-close at 10 and 2 o'clock.
Yeah. Yes, yes.
So let me just tell you, we in the Protect trial, we are 62 patient Protect 2. Now, of course, this current Protect, we are 75. Then we did a Shield trial, off and on, we did total 54 cases. We did Magenta, 15 cases. Then we did
you mentioned Protect?
No, Magenta. And then we did with the ECP and all combined. We are talking about 300 cases of high-risk PCI. And guess what? How many came out of the cath lab with Impella? 0. Fantastic. 1 patient, Protect 2, we changed it to the balloon pump because there was a side branch closure. That's the only case we have. Protect the Impella was changed to a balloon pump because of persistent chest pain. But of the 300 patients randomized in the trial, these are the complex cases, and 0 out of the cath lab. So everyone, if you have done the good job, you should be able to take it out just like shown here.
And what happens, when do you stop the anticoagulation?
No, anticoagulation is continuing.
Continue.
Okay. Yeah. For how many? 2 hours, 4 hours? How long?
No, this is patient is on heparin. Large bore access are always done on heparin for any reason. If we have a bleed, we can just give protamine. Otherwise, majority of our cases are done on angiobanks. This is done on heparin. And so we do not give reversal like protamine for this case because we just did a stent. So whatever the last ACT was, 3 or 4. So we closed it. So we are not giving any more heparin. By the time the ACT keeps going down, it will take over an hour. It'll be fine. Yeah.
And based on the trial of if you use a bivalvulotin for some region, let's say patient has a heparin, HATE or COAS, that will go with the same protocol, the total 3 hour of infusion. Start to end, minimum 3 hour if patient is naive for antiplatelet therapy. This patient apparently was taking
I gave after the patient, after the last we gave a Plavix.
Just to clopidogrel along with the Eliquis patient was, but naive case we still go with the 3 hour, and that is what has been shown. That made to the guidelines now, bivalvulotin back again as a class 1 indication over heparin STEMI patients because showed a lower bleeding and mortality.
Samin, there were a few questions. I'll just take a moment because this was important as you were giving the colchicine talk. If colchicine it shows good results as it does suggest, does it complement statins or is it an alternative? I mean, there's so many complications with the drug.
No, I would say it's additive. It
cannot alternative.
No, it cannot be alternative. No. Statin has shown to be beneficial.
Not alternative, additive.
Yes,
100% additive.
Yeah, shown to reduce the CRP and all those, and the inflammatory markers. So colchicine may add on. So I can tell you, when those Lodoco trial and all those came, we were very excited. We start giving it to the patient, and guess what? Within 1 year, no benefit. So what really made difference was ranolazine, not the colchicine. So I would say that give your ranolazine. If fails, then maybe you can add colchicine. Then they came up with the new medicine. Colchicine available is 0.6, which is a $2 tablet. I mean, means 1 month is like $15 only. Then they say, well, because of the patent, 0.5 millimeter, the tablet came Lodoco, Lodoco, available 0.5 milligram, and that tablet is $400 per month.
Yeah.
So 0.6 is $15. 0.5 milligram is $400. So we stopped prescribing. I don't know whether they'll continue, but because of the patent,
Welcome to the brilliance of Wall Street. Anu, exceptional skills, great teaching case, brilliant results. Thank you for this superb. Congratulations to your fellows also who have done a remarkable job, and the cath lab staff. We finished this session and we'll see you on May the 20th for our next.